Hello, everyone, and thank you for joining us today. We are your host, ASPHP, and our webinar is entitled Safe Client Handling in Home Care, a Problem-Solving Approach. And we'd like to let you all know that this webinar, we really need audience participation. Our presenter is just asking that you guys give your input throughout the duration of the webinar. And if you've been with us before, you know that all of our webinars have our attendees muted. And so your participation is not required, but requested to happen via the chat box. So please, again, for the duration of the webinar, please feel free to just chime in with your thoughts and questions. So again, our presenter today is Emily King, and my name is Tamara Armstrong. I will be the facilitator. Emily King's goal is to improve safety and independence in home care. She is currently a postdoctoral fellow at the University of Waterloo, where her work explores the tasks, circumstances, and patterns of activity that put home care providers at risk of injury. Emily's doctoral research at the University of Toronto and the Toronto Rehabilitation Institute focused on analyzing how caregiving in private homes puts paid providers at risk of musculoskeletal injuries and on identifying tools and techniques for preventing injuries. Emily is also heavily involved in the design of assistive devices for both home and institutional use. She holds 4 patents and has contributed to development of assistive technologies for toileting, mobility, and safe patient lifting. Welcome, Emily.
Thank you, Tim.
You're welcome. So before we get started, I want to go over a few housekeeping rules. So as I stated before, audio is muted throughout the presentation and it opens for Q&A session during the final 20 minutes. If you have an urgent comment or question, or like I said before, if you'd like to chime in with thoughts or questions throughout the webinar, please do so in the question box. Once the Q&A session is open, just if our presenter would like, we will or we may open audio for you. If you're not getting quality sound from your computer, feel free to dial the toll-free number given to you via email upon sign-up. Please remember that ASPHP does not endorse any particular manufacturer, device, product, or company. And ASPHP is approved by the California Board of Registered Nursing to provide the contact hour for today's presentation. All right, Miss Emily, without any further ado, I'm going to hand the screen over to Emily King. It's all yours, Emily.
All right, so I think you can all see what we've got there. Getting my go-to webinar panel out of the way, and here we go. As Tamara said, I'm going to be talking today about safe client handling in home care and trying to take a problem-solving approach to this. My background, Tamara's given you one summary. I also just want to emphasize I come from really an engineering background. When I'm giving this kind of a presentation, I do like to add the disclaimer, I'm not a clinician. So engineering, not clinical. But my bachelor's was mechanical engineering with biomechanics option. My master's focused on why falls happen more as we get older and how they can be prevented. And then I really shifted for the PhD and postdoctoral work to look at helping people to live well in their own homes for as long as possible, as independently as possible, without hurting their caregivers. And a lot of the work that I'll be presenting today focuses on caregiver safety. It doesn't mean I don't think about or consider independence, and certainly the more independent somebody is, the more that tends to promote caregiver safety. But that's the lens that you'll be seeing most today. I'd like to learn more about you as well, so that I guess I know how to target my presentation, whether there are places where I should be providing more detail or less detail. So if you're able to share with Tamara in the text box, and then she'll provide a summary for me. Which sector do you most closely associate with? Is it home care? Is it long-term care? Somewhere else? What's your primary role? Are you educators, clinicians, researchers, or other? And is there something special that you're hoping to get from this webinar? What was it that attracted you to sign up today? So I'll give you a moment to think about that, and let Tamara share results as you enter them. So Tamara, do we have anything coming in?
Yep, I'm going to give it just a second. Okay, we have workers' comp, loss prevention, home health, safety consultant, work with home care companies, PT, OT, RN, home health aides. We have another home care. So it looks like the majority is home care.
Great.
And
okay, and if there's anything special people are hoping to get from this webinar, if you let me know, then I'll try to do that. Otherwise, I'll proceed.
So all of the responding to the first questions. If anyone would like to respond to the third, that would be great. Is there anything special you guys would want to get, or like you said, you could just proceed, but it's mainly home care for the sector. Okay.
So hopefully this is pretty relevant to everyone then.
Right.
So my plan for this webinar is to discuss some of the safe client handling and mobility challenges that are specific to a home environment. This is sort of what I found from research. If you would like to chime in at any point, if you have perspectives you'd like to share as I go through this, please feel free to do that. And then when you make comments, I've invited Tamara to interrupt me as necessary to share those before we move too far from those points. And then to systematically evaluate a couple of common home care activities to identify potential risks and strategies for managing the risks. Something that I think is fundamental is that safe caregiving takes problem solving, especially in home care. One size does not fit all, can never fit all. I'll discuss reasonably common circumstances, but I'm not saying that these solutions are always going to work for everybody. That would be absurd. When I'm thinking about caregiver injury, I'm thinking about I'm thinking a lot about musculoskeletal injury, and I'm thinking a lot about two different types of injury. These injuries can be acute, so there's a sudden event. Most commonly when I read injury reports, this will be something like a care recipient falls or collapses, just his knees gave out, and then the caregiver was trying to catch them, and that's when the injury occurred. Or it can be, poor coordination or cooperation between caregivers or with the care recipient. So sometimes this is the client tried to sit too early. Sometimes this is, the other caregiver tried to move on 3, not after 3, that kind of thing. The other kind of injury I'm thinking about is cumulative injuries. So these are the ones that it's harder to know exactly what causes them, but they may actually be more common in caregiving than acute injuries. So cumulative injuries are a buildup of small bits of damage over time. Each time, it's not really enough to feel or to hurt, but the damage is building up, and eventually it will get to a point where it causes some level of ongoing problem or disability. And in some cases, persistent pain is a sign that this is becoming a problem. So I focus mostly on back injuries because most caregiving injuries are back injuries. but I'm sensitive to the fact that the shoulder is really next up, and there are sometimes you encounter back-saving strategies that just transfer the strain to the shoulder, or indeed further down the arm, something like that. So, primary focus tends to be on the back, but I am aware of especially the shoulder as well as the most commonly, about the second most commonly injured body part. Most of these injuries for home health care workers are overexertion injuries. And so that will be my focus, these overexertion injuries that tend to lead to the musculoskeletal problem. A quick word, though, on slips, trips, and falls. I'm located in Toronto, Canada, and so we get, some fairly serious winters. And slips, trips, and falls are the second most common type of injury, and the vast majority of that is wet, icy, and snowy surfaces. So that's not the main purpose of today's presentation, but if you're interested in learning a bit more about what the research teams at Toronto Rehab are doing about slips on ice and snow, you can check out this link here, and you'll find some presentations that will give you some ideas about what we're currently involved with in terms of safer footwear for icy, snowy conditions, which is something that's very important for visiting home workers in unpleasant cold climates. But, as I said, overexertion of the back is really where I'm going to focus most of my effort. So avoiding back injury, the sort of simplest statement on how to do that is that, we've got back risks we need to be aware of. Non-neutral trunk postures, so flexion, lateral bending, and twisting, especially in combination, and or trying to lift too much weight are the things that we have to be aware of. Of these, flexion tends to be both the most common and the riskiest, although twisting while carrying heavy loads is also something that we really need to watch out for. So these are the key risk factors that I'm looking at when I'm evaluating an activity. Now, talking about avoiding the risks is super easy to talk about when we're just talking in empty classrooms, but it's a lot harder in real life where stuff gets in the way. So just to say that I'm aware that that is hard to do in practice a lot of the time. However, we can try to adapt the way that activities are performed to minimize the risks. So, back to the central point of the webinar. Let's start by describing and discussing safe client handling and mobility challenges that are specific to home care. First, I want to acknowledge that there are a lot of general occupational hazards in a home care context that don't necessarily exist in institutions or not to the same degrees. So client homes, some home environments are inherently dangerous, and sometimes they are made dangerous by choices that the clients make. They're not set up as care environments, so even in the best case, you're dealing with something that wasn't designed for care. And often the access to equipment is poor. Interactions with clients and families can be one of the best parts of home care, but can also be overtly negative. And so obviously this affects, home care worker experiences and the kinds of solutions that home care workers might feel that they are able to propose or to try to insist upon. I hear a lot of complaints about inadequate organizational support from home care workers, especially if they don't feel that that their supervisors take concerns seriously. So often home care workers feel that they're very much on their own. And then there are the demands of the care work, which are heavy. So, there are awkward postures, physically demanding work, heavy clients, cramped spaces. There are, it's physically demanding work in environments that are sometimes reasonably good and sometimes very challenging. And so I want to acknowledge that up front. In terms of activities that are of greatest concern. There's been a lot less work on identifying and characterizing actual activities than on characterizing general risk factors, such as the ones that I've just covered. There are two papers I'd like to bring to your attention. A great paper by Owen and Stahler in 2003 identified home care workers' perceptions of their most demanding activities, and these were repositioning or lifting clients up in bed, assisting with transfers, providing a tub or bed bath, assisting with compression stockings, repositioning on a chair, toileting, or assisting with range of motion exercises in bed. A more recent study looked at where injuries tend to happen and looked at characterizing the level of exertion in each setting, and found that the bedroom and bathroom were like, those activities were likely to be the highest exertion, and they were also the most common locations for in-home injuries. And that pretty much matches what we're seeing from the list of demanding activities. However, when I was starting my PhD, what I felt is that I needed more information than this to go on to decide how to examine and address challenging home care activities. So I conducted my own focus groups with home care providers, occupational therapists, physical therapists, nurses, personal support workers, personal support worker supervisors, and various forms of management, and asked providers to identify their top issues, their pet peeves as to what made home care difficult and dangerous. And so I broke the results into sort of two sections. Challenges to in-home mobility and challenges in bathrooms. So for in-home mobility, the care context echoes a lot of what we see in the existing literature, but emphasizes also working alone, problems of communication between providers, clients, and families, and scheduling pressures, which if you work in home care, I'm sure you're familiar with. In terms of the specific challenges, they identified assisted walking. They were saying when they're helping clients to walk, basically they're acting as a fall arrest system. Often there's not very much else that a client is using to help maintain stability apart, and they are often relying quite heavily on the care worker. In terms of stairs, there are existing solutions, all of which seem to require major changes to either lifestyle or homes. And transfers, repositioning, and mechanical lifts were a real hot button issue. Lifts seem to be underused. They often don't really fit the environment, or are so awkward to use that manual techniques take over. Overhead lifts are far, far easier to use than floor lifts. Floor lifts are rarely a good fit for homes, but overhead lift availability is limited. Something that I'm not sure how common it is in your environments, but that's becoming increasingly common up here is portable overhead lifts. So there are actually basically temporary frames that you can put in over a bed or a chair to temporarily install an overhead lift in a setting where perhaps you can't install a ceiling lift, or where the lift is only expected to be required on a short-term basis. And that's something that was not particularly common when I ran these focus groups, but that is becoming more common and addresses many of the challenges with both overhead and floor lifts. Slings were also called out as being hard to place and often holding clients in a poor posture. So those were in-home mobility challenges that I saw. Challenges in the bathroom, toileting and bathing. So in toileting, especially assisting unsteady and unpredictable clients with toileting transfers, with providing perineal care, and with managing clothing. In bathing, it's transfers in and out of the bath or shower, particularly getting the legs over the edge of the tub, and again, assisting unsteady and unpredictable clients. A theme that came out particularly strongly when toileting activities were being discussed was the importance of normalcy. While there was a big drive to try to help people to bathe and toilet in a way that was as normal as possible for them, as much like what they used to do as possible. So there was a real resistance to common solutions such as commodes that would avoid some of the awkwardness of toilet transfers, because basically a lot of clients didn't like them at all and found them distasteful. And so really the caregivers that I talked to did feel under pressure to try to provide care in a way that was, as I said, as normal as possible. And often that led to an increased reliance on manual handling and having to deal with awkward spaces. But they felt that that was an important part of providing good care. So those are some challenges. So we need to pick some of those challenges to systematically evaluate and to try to identify what the risks are and how to manage those risks. And when I asked these focus groups, where should I focus, they said, focus on the bathroom activities. They said that is where a lot of the major challenges happen, and that's where a fair number of injuries happen as well. And certainly here, that is one of the key reasons that personal support workers or home care aides are going into client homes, is to provide bathing and toileting care. So my way of addressing this systematically was to start with high fidelity home care simulations, so that I can measure things without invading people's privacy too much. So I invited practicing community-based personal support workers to come in and assist a standardized surrogate client with bathing and toileting. The standardized surrogate client was portraying somebody who was cognitively competent, but frail and with a fear of falling, and somewhat prone to hypotension. And the instructions were really just assist the client the way you would in your usual practice. So my goal in this study was to observe under these fairly good bathroom conditions, like it's a fairly common bathroom layout, but it's not as bad as some of them get. How would people provide care, and where are the risks in how they're providing care? And then I didn't want to let them know that I was looking at postures specifically, so I didn't tell them I was doing that. But I used a video-based postural analysis system to analyze their postures afterwards and work out when they were in the most awkward postures. So for toileting, what's the hardest? You need to line somebody up, undress them, assist them to sit, they do their business, provide perineal care, assist them to stand, and then dress them. Looking at the postures that people are adopting, we see in the lightest colors here, we see relatively neutral postures moving to the darkest colors, or the most severe flexion angles, or in this case, lateral bending or twisting. And when we look at where people are in the most problematic postures, we see it's when they're lowering the client's pants and underwear, when they're providing posterior perineal care, and when they're replacing the clothing. If we consider the potential for supporting some of the client's weight, assisting the client to sit and stand also start to raise some concern. So I analyzed the approaches that I was seeing care providers use for each of these activities. For providing perineal care, I didn't see any clear best technique. Everybody was in quite an awkward position while doing this, or they were in a moderately awkward position and the client was standing, which in the case of somebody with potential balance issues may not be a safe choice. However, bidet seats exist already. This is something that you can buy at the hardware store for a couple of $100. It removes the need for human assistance with perineal care, which, when you combine the posterior and anterior perineal care, accounted for, in my simulation, 1/3 of the time in severe bending. I suspect the actual number is higher because my simulation did not involve actually having to clean anything off of the client's skin. So I think that bidet seats should be used much more commonly than they currently are. And I would encourage you to encourage clients to look at these seriously. For clothing management, in both lowering the clothing and replacing the clothing, if the waistbands were deliberately lowered below the knees, which was some personal support workers' default, this isn't something that I asked the client to request, then the demands on the personal support worker's back tended to increase. The loads on the back increased, the time required for the activity increased, and the time spent in awkward postures increased. So my recommendation there is, if it's possible, if the client doesn't mind, then having the default of only lowering the waistbands to the knees will reduce some of the exposures. In terms of assisting the client to sit and stand, again, I did not observe any clear best technique. Everything looked pretty awkward. A technique that's commonly taught, and that I'm sure you've all seen, is to try to stand beside and slightly behind a client, support their hip or their upper buttocks with one hand, the hand or shoulder with the other, and move with them to assist them to stand up out of a chair. It looked a bit like this one person was trying to do that, but there wasn't enough space for them to stand beside the vanity to do that. There was another study performed in Scandinavia a couple of years ago that used a much more open bathroom environment and did find a lower incidence of awkward postures. Now, while I don't know exactly what postures people were adopting in that study throughout the work, I would suggest that it's worth taking a good look at whether increasing the space for a provider to stand beside the toilet will reduce exposure. Certainly, it would enable the ideal taught technique for assisting clients to stand up. Also, though, if a client is able to stand independently, there's much less for the caregiver to do, and arguably it's better for everybody. So I just thought I'd flag some alternative tools for sit to stand. Armrests, I'm sure you're all familiar with. Walkers are sometimes used, although I know there's some controversy around how stable they are for assisting clients to stand. I haven't seen transfer poles used as much, but they provide a very stable way of allowing somebody to move forward towards the support and to pull if necessary. So a single transfer pole or two transfer poles installed in front of a toilet is another option for helping somebody, for providing quite substantial assistance to somebody as they stand up off of the toilet. Raising the height of the toilet is also helpful. I'm sure you're all familiar with raised toilet seats, but I should also mention the toilevator or bottoms up are two different names it's marketed under. There are these toilet risers that you can install under a toilet as well that can also make help to raise the height of the toilet and make it easier for people to get up. On the armrests or a walker question, I did have personal support workers assist a frail client, same profile, using both armrests and a walker. And generally they found that armrests tend to get in the way of providing care. And also, if a client is leaning forward, there's some fear with armrests that they don't have anything to lean against, that they're leaning out into empty space. That was especially during perineal care. Whereas with a walker, the client and the worker both seemed more comfortable in that they were able to be closer to each other. So that's just qualitative at this stage, but it's something to consider, how involved a caregiver is going to be in care when you're looking at whether armrests or some other solution would be best for assisting somebody to get up. In terms of transfer poles, as I mentioned, they're a stable way to increase the base of support and reduce the horizontal momentum needed to stand up, which is one of the things that sometimes worries people. either with one pole in the middle or a pole on either side, positioning it about 75% of thumb tip reach, as pictured here, seems to be about the ideal distance for assisting somebody to stand up. The pole takes more of the load during the sit to stand, reducing individual joint forces. And I can provide a reference for that if anyone's interested. But let's move on to the bath, because that's another major area of concern. Using the same format as before, using that realistic simulation of bathing activities, I found that care for the lower limbs, washing, rinsing, drying, applying lotion, regardless, always involves an awful lot of bending. Transferring into the bathtub could also involve a fair bit, and you've got the potential for a fair bit of load when lifting legs or assisting a client to move across a bath bench as well in that. And again, clothing management's a bit of a challenge. I'm going to focus, though, on getting in and out of the bath and on foot care. I'm going to focus specifically on seated bathtub entry and exit, although I'm also a huge fan of grab bars and happy to talk about those if people are interested. First, let's talk about transferring the legs. When we're transferring the legs in and out of a bathtub, there are a lot of factors that make this difficult. There's a severely flexed posture to lift the foot from ground level. Legs can be heavy due to swelling, stiff joints that provide resistance. And then there's a question of how much the care recipient can help or is asked to help in some cases. And there's a high obstacle to lift over. So if we look at each of these in turn, we reduce the weight of the lift. One thing I don't have on this list is if there's the potential for medical management of some of the stiffness and swelling. That probably should be on the list. From the perspective of a care worker in the room at the time, lifting one leg at a time is one step, and then looking for more ways for the care recipient to help. One thing that I observed in my various simulations and that I've seen as I watch how care is provided is that some caregivers will tend to ask the client to participate a lot, and some kind of forget to do that and will find it quicker or easier to just do something for a client. And will come up later as well is that trying to do something for a client rather than trying to get the client to assist with it, not only is that less good for the client, but it also tends to put the worker often at more risk. So can we reduce the height of the lift? That would be less destabilizing and better for stiff joints. Also easier on the caregiver. Often visiting home care providers don't have the option to modify the bathroom, but if the family is willing, there are walk-in tubs, more expensive, or it's possible to get bathtubs modified. This is something that not all families are willing to do. I know there can be a lot of resistance to it, but if it's an option, it certainly makes getting in and out of a bathtub easier. Oh, and that modification is on the order of a couple of $100, I think. So the final option is, can we reduce the bending needed to lift the legs into the bathtub? So I did a second simulation to look at that, comparing the standard technique, what everybody did in my initial care simulation of stooping to lift the legs, to using a short-handled leg lifter, or to sitting on a short stool to lift the legs into the tub. Again, I got community-based personal support workers to show me how they would use each tool. Same client profile, frail, some fear of falling, but cognitively competent. And I solicited the providers' feedback on which tools they liked best and how well they thought each tool would fit into their regular home care practice. And I measured the postures of the trunk and shoulders and the muscle activity in the back and shoulders for each of these tools. So I'm going to take you very quickly through my quantitative results. The summary is forward bending was decreased by the leg lifter and by sitting to lift. Other trunk postures weren't affected. The leg lifter took a little longer to use in a slightly flexed posture. Arm elevation, how far the shoulders had to be lifted up, was decreased by using the leg lifter but increased by sitting to lift the legs. And muscle activity told a similar kind of story, where muscle activity tended to be decreased by using the leg lifter in both the back and shoulders, but increased by sitting to lift the legs. Qualitative feedback also backed that up. Everybody liked the leg lifter the best. They found it reduced bending and effort. Sitting to lift reduced the bending, but was not perceived by most people as being worth the hassle. Half of the PSWs either refused in one case or in the other 3 cases strongly disliked it. The other half had something nice to say about it, but then sometimes came out against it anyway. The people who did favor sitting to lift were also considering that they could sit to lift the legs into the tub and then stay and wash the feet there for a while. And indeed, some people already do that. Overall, summary for ways to make it easier to lift the legs into the tub. The leg lifter was easier on the back, easier on the shoulder. However, it's an extra tool that costs about, I don't know, 40 or 50 bucks. Budget options might include a towel or some other loop of fabric. I have not exactly tested those. Similar principles may apply. So that's something I'd like to test at some point, just to confirm that that has the same benefit. Sitting to lift the legs was much easier on the back. You can see our caregivers in a much more upright posture, but it's harder on the shoulders and arms. And sitting was a lot more work for the legs, so most people felt that just wasn't worth it. Before I move on, Tamara, do we have any questions or comments?
No, we don't have any so far, Emily.
Okay. So for shifting people across the bench, the bath bench, because I was really looking at a situation in which we were using at least a basic bath bench to transfer in and out of a bathtub, which is appropriate for somebody who is frail and has some balance challenges. The postures involved are often quite awkward. Some of this might be addressed with how to position the bench, although your options are often quite limited. And then there's the question of how much help actually needs to be given and where the hands need to be placed to do that. So PSWs who assumed that they would need to really shove the client or push more forcefully across the bench tended to have to bend more to position their hands appropriately to do that, as opposed to PSWs who tried to guide the client and encourage the client to boost and shift herself more across the bath bench. And then reducing the force needed. Again, a key question was how much can the care recipient do for themselves, and reminding the care recipient and coaching them as to how to do that. I also examined a friction-reducing bench, or budget options, as I call them. So using that same sort of second simulation I showed you before, where I'm able to measure muscle activity and postures, I examined using a standard bench as opposed to using a sliding rotating bench, as opposed to using a garbage bag, which was an idea that a worker in the previous study had suggested for reducing friction. So, very briefly, the use of awkward trunk postures was increased by both options. That doesn't look good. One of the main reasons, though, was that the buttons on this chair were really awkwardly placed. So if you wanted to release, especially to release this catch to help slide somebody back out of a bathtub, there was a lot of bending and fiddling because people hadn't had as much opportunity to get used to the device and because it was just hard to see. Arm elevation was also increased by both options. So that doesn't look good either. However, muscle activity in the back was decreased by using the sliding rotating bench. So even though we're seeing people having to support their trunks in more awkward postures, we're seeing that their backs aren't having to work as hard. So that's encouraging. And the qualitative feedback was also more encouraging in that it said they were saying that the sliding rotating bench was making the transfer easier. Everyone preferred it to using the standard bench. They found it easier to push the client and easier to pull her back. However, they did complain the release buttons are hard to access. They wish the seat locked near a 45-degree angle. It only locked at the position you see or 90 degrees to that, which is kind of awkward. And there were real concerns that this would be too expensive for many clients. Certainly here, clients are responsible for providing their own equipment. So there were concerns about that. The garbage bag was perceived as being a good option if the sliding rotating bench was unavailable. 2 people even preferred it to the sliding rotating bench, despite the fact that in terms of shoulder effort and back muscle effort, I found no quantitative benefit. Okay, so why on earth is that? Well, it turns out a lot of this came back down to technique. So when I took a closer look over the videos and examined what had been going on, in the garbage bag case and the sliding rotating bench case, the personal support worker was really pushing the client or pulling the client. When only a standard bench was used, the personal support worker was encouraging the client to boost themselves along the bench. So providing that encouragement to the client to boost themselves along the bench had the same level of benefit as this friction-reducing garbage bag, which is interesting. I also measured the forces that were actually required to help somebody into or out of a bathtub using each of these options and the standard option. Basically, the sliding rotating bench substantially reduces forces. The garbage bag reduces forces a little bit, like notably if somebody's not helping. But if we look at cheaper and easier ways, wetting the bench, just hosing it down before assisting somebody to move in, was just as effective as using the garbage bag, but without some of the downsides that personal support workers identified with the garbage bag, which were that they had some worries about the client slipping off the front of the bench when the garbage bag was used, and they had some concerns that the presence of the garbage bag would complicate cleaning because the drainage holes are blocked. So in this case, I'd say wetting the bench is easier than a dry bench and offers the same benefits roughly as the garbage bag. So those were interesting findings. In terms of washing the feet and the lower legs, which were another key activity that I identified, this is what the typical posture is while that's happening. There's a lot of very severe bending. And so I evaluated a number of ways of getting nearer the feet. And the quantitative results I haven't got ready to share yet, although in general, many of these did lead to more upright postures. But when I asked people how practical these options would be, the very common response was, but of course, not a lot of their bathrooms are really clean. So this is a very important factor in that some of the personal support workers in my study were actually paid to clean a bathroom before they provided a bath, and some were not. Generally, the ones who were not said they would not use any of these techniques because they involved getting far too close to a potentially very unsanitary bathroom and to the floor and to the toilet. The people who were paid to clean ahead of time were much more open to using some of these techniques that could be a lot easier on the back. So that's a case where the context could really affect what solutions were appropriate. So those are the core suggestions that I had for you today. I am happy to talk about some of the other home care safety challenges, but since I promised a systematic evaluation of some activities. Those are the activities that I have evaluated most systematically. I'm happy to take any questions that you have.
Thank you for that. Yeah, we're here. So thank you for that webinar, Emily. We don't have questions right this second, but if you'd like, we can wait for a few minutes. If any of our attendees want to type in the question box any questions for our presenter, now would be the best time. And we'll wait a couple of minutes, Emily, if you'd like.
Sure. If questions are not coming in, I can also give you my thoughts on grab bars, but I thought it would be better to leave a bit of time for discussion, since if the attendees are involved in home care, I'm interested to hear your thoughts on how these solutions would apply in your context.
Right. So we do have one question to which I can answer that. Tricia would like to know if they can get the PowerPoint, and Tricia, the PowerPoint will be available along with this recording tomorrow. So all attendees will get that via email. And Emily, if you want to just kind of continue with your discussion, that would be great. That'll give them time to type in their questions if they have them.
Sure. There was another study I wanted to share, but I wasn't sure I'd have time. So a systematic look at task demands of getting in and out of a bathtub while standing. So a bathtub has a slippery surface and requires a step over a high obstacle. We were interested in how to make this activity safer for somebody performing it independently. So you can look at having a bath mat or a textured surface. You can look at a grab bar or improvised handholds. And we were interested in how these common interventions affect the balance control during transfers. So we looked at no intervention, which is either stepping in completely unaided or leaning on a wall. We looked at improving friction in the tub using a bath mat. We looked at providing a handhold, so either a vertical grab bar on the sidewall or a horizontal grab bar on the back wall. And we compared those specifically because there's some interest in Canada, at least, in whether or not grab bars should be mandatory in around baths in new builds or in severely renovated bathrooms. If there is a grab bar, where should it be placed? We evaluated balance control by tracking people's center of pressure, which is a reasonably good indicator of how well controlled their balance is as they stepped in and out of a tub. We had them step in, pause, step out 3 times for each condition, and we had sort of a simulated SOAPy solution. We did this with young and older adults. And we evaluated a bath mat, no assistance, putting a hand or 2 hands on the wall, whatever people felt comfortable with, or having a vertical grab bar on the side wall, or a horizontal grab bar on the back wall. And without going through the details, what we found is that for standing tub entry and exit by the healthy young and older adults studied, control was improved by either leaning on the wall or using a vertical grab bar. But of course, we'd expect a vertical grab bar to be much handier if there was any loss of balance. Using a bath mat, control improved a little during entry. So that you expect it to reduce the likelihood of slips, but it's interesting that balance control itself also improved a little bit during the transfers when a bath mat was used. And while it may be helpful for other aspects of balance, we confirmed that a horizontal bar across the back of a bathtub does not offer any improvements to balance control. It actually made some metrics worse. So that's my very brief summary of, if you need evidence on why people should install grab bars, we're working towards why and where. And that's something else that I'm happy to talk more about if people are interested. Oh, and of course, grab bars help caregivers too. When when I had a caregiver assist this frail older client get in and out of a bathtub, if you're able to install 2 grab bars rather than just one, so one grab bar located slightly inside the tub, one located slightly outside the tub, then you're giving the care recipient the option to move from a stable point to a stable point rather than just pivoting around one grab bar. So that, I know it's not always feasible, but if somebody is able to install grab bars in both locations, that's something that looks like it could be beneficial. So that was the small bonus. Back to there. So if, again, if anyone has any questions, I'm happy to answer them. If anybody would like to follow up, my email address is on screen and will be in the PowerPoint that's shared.
Thank you, Emily. There is one question. Someone would like to know, what about pushing home equipment, i.e. Hoyer, on various surfaces?
Yeah, so
etc.
Pushing Hoyer lifts on, there is evidence to show that even manipulating a Hoyer lift on an ideal institutional floor is still much more demanding and less safe than using an overhead lift. And those are references that I can share if you're interested. My colleague Tilak Dutta did some excellent work comparing floor and overhead lifts and looking at the specific risks of using Hoyer lifts, even on institutional flooring. Once you introduce carpets, thresholds, even more compliant floors, that gets much harder. I'm not a fan of floor lifts in home settings, or in most home settings. And that's one of the reasons that I'm very interested in the temporary overhead lift tracks. If somebody's not able to install a full-on overhead lift track in their ceiling, the temporary overhead lift tracks at least don't require the kind of pushing on, carpets and around clutter that the Hoyer lifts do. I didn't make that a focus of this presentation, but if you want to send me an email, I'm happy to send you more materials on that, because that's something that that our research team has also been looking at.
Okay, great. Thank you so much, Emily, for that very informative webinar. And we'd like to thank you all for attending our webinar today. All registrants will receive a post-webinar email with the PDF of today's presentation, as well as a link to the webinar evaluation. Please complete the evaluation in its entirety in order to receive a certificate of completion recording 1 contact hour. Stay up to date on all upcoming webinars and educational opportunities by visiting us online at www.asphp.org. Again, thank you, Emily, so much for presenting today, and thank you, attendees, for joining us. Have a great day, everyone.